I want to tell you about someone. Her name is Renee. She's 52 years old, a home health aide, and she has been managing lower back pain for 11 years. She has seen 6 different providers. She has been prescribed muscle relaxers, anti inflammatories, and at one point, opioids. The opioids scared her, so she stopped taking them. The anti inflammatories upset her stomach. The muscle relaxers made her too drowsy to work. So she stopped everything and started managing the pain on her own. Heat packs, ibuprofen when it gets bad, and just pushing through the rest. Nobody ever asked Renee about her sleep. Nobody ever asked her about her stress levels, her diet, her movement patterns, or whether she ever tried anything other than a prescription. She has been treated as a pain score on a scale of 1 to 10, not as a whole person living inside a body that hurts every single day. Last year, she missed 3 weeks of work because of a flare. She cannot afford that again. Her daughter's in college.
Renee is not a rare case. She is the rule. And the research is telling us that the tools that could have helped her were available the entire time. They just were never offered.
Today, we're talking about non-pharmacological pain management, what the science actually says, what works, who it works for, and why the communities that need these tools the most are the least likely to receive them.
If you're new here, welcome to the Melanin Initiative. I'm Geraldine and I co host the Melanin Initiative along with Kimberly and Alicia. Here, we simplify medical information into language that you can understand. We create a safe space for you to ask questions and to share our nursing perspective. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. Our mission is twofold. One, to simplify complex health information, and two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. If you haven't already, subscribe on Apple Podcasts or Spotify and leave us a 5-star review. Thumbs up the video, leave a comment, and share the show with your friends. This shows the algorithm that this content is important so that when people like you look for information like this, we'll show up higher in your search results. As a reminder, this show is for educational purposes only. The opinions expressed are our opinions alone, and they are not a representation of any of our affiliations. If you are experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. And if you're having a physical emergency, you can call 911. If you're having a mental health emergency or know someone who is, you can call 988 or text 741-741.
Thanks, Geraldine. So let's define what we're talking about. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That definition matters because it includes the word emotional. Pain is not purely physical, and it never has been. And any approach to pain management that treats it as purely physical is going to fall short. There are 3 time-based categories. Acute pain lasts 0 to 6 weeks. Subacute pain lasts 6 to 12 weeks. And chronic pain, the people we see the most, persists most days or every day for a minimum of 12 weeks, typically lasting beyond the anticipated time for tissue healing. We're talking decades. Some people have been living in pain for decades. Chronic pain does not always mean something is still damaged. It means the nervous system has learned a pain pattern that it keeps repeating. That distinction changes everything about how we treat it. Now, how common is chronic pain? Well, in the United States, it affects 20 to 50% of adults. Low back pain alone incurred the highest healthcare cost of any condition in the country. And if you're in healthcare, it's the number one injury. And this has
Mhm.
been going on since 2016, $134 billion. Globally, low back pain has been the leading cause of reduced function since the 1990s. That same year, over 57 million years lived with disability were attributed to low back pain worldwide. Among older adults globally, chronic pain prevalence sits between 13 to 62%. For older adults, specifically in clinical settings, that number goes up to between 28 and 60%.
Wow, Kimberly. Those are not small numbers. That is a significant portion of the people in our communities who are waking up every day in pain and trying to manage it with tools that may not be working.
And like I said, that's us, that's our peers. And the research on the tools that we have been relying on is direct. One source describes the overall impression of pharmacological. So, pharmacological it means like a medication or a drug. It's funny because we say medication or drugs, but patients, when they hear that, they're only thinking of prescriptions, right? They don't think about things over the counter or even things that they're mixing at home. But we're just talking about anything that is usually like a drug. And this is for chronic pain. And I'm quoting here, rather sobering: the effects on pain reduction and improvement of function are commonly small to moderate, short lasting when compared to a placebo, and accompanied by high risk of adverse events like nausea, constipation, overdose, and addiction. These are the things people complain about the most, and these are the things people are afraid of the most. That is in the clinical literature on medications we have been defaulting to for decades. Now, who carries the highest burden? Not surprisingly, are older adults who face compounding challenges from age related physiological changes, as your wear and tear, multiple chronic conditions like diabetes, even cancer that leads to things like neuropathy, and the dangerous interactions of effects of polypharmacy. This is when you take multiple medications. Now, when we talk about our vulnerable populations like veterans, and we'll come back to this in a little bit, who experience severe pain at a rate of 50% greater than people who are not veterans. Pediatric patients in palliative care, and people experiencing socioeconomic disadvantage, among whom low back pain is disproportionately prevalent. That means we're seeing it more in those populations than in the general population. The research we're drawing from today does not contain specific disparity data broken down by race or ethnicity, and that gap in the literature is itself a clinical and ethical problem we are naming directly. This is for all of our students. Even if you're at your bachelor's program, you can be involved in research. If you've graduated and you're on the floor now, you're working in some clinical setting, you can address these gaps. What we know from the broader pain research is that Black and Brown patients are systemically undertreated for pain and are less likely to be offered non-pharmacological alternatives and are more likely to have their pain dismissed or minimized by the healthcare system. It's been well documented that we're being taught this in our training, that people of color have a higher pain tolerance, and that even though we're told that pain is what patients tell us, we know for a fact we believe what we think it is based on how they look and how they sound. Now, Renee's story is not accidental. It's a pattern that we see every day.
And this is exactly why this conversation belongs on this podcast and in these communities. The tools exist, the evidence exists, the access and the offer. Are what we are missing.
Now, before we get into specific interventions, I want to spend a few minutes on the science of how pain works, because understanding the mechanisms changes how you think about what can help. First, we have the gate control theory of pain. It's one of the most important frameworks in pain science and one of the least explained to patients. The concept is that pain signals travel from your body to your brain and pass through a series of gates in the spinal cord. That's in your back. Those gates can be opened or closed depending on a range of factors: emotions, anxiety, just the thought of, oh, I'm going to move, or the thought of, I need to go have this procedure can trigger pain. We see it all the time. Fear, frustration, and stress open those gates, amplifying the pain signal, making it even bigger. Physical interventions like massage and electrical stimulation and cognitive approaches like cognitive behavioral therapy, which we've talked about before here on the channel with our in-house trauma specialist, Kelsey Wilson, can close those gates, interrupting the signal before it reaches the brain. This is why telling someone to just relax when they're in pain is both unhelpful and physiologically backwards. Their anxiety is literally making their pain worse through a documented neurological mechanism. And it is why treating pain only at the physical level with medications misses half the equation.
Man, Kimberly, that is something I wish someone had explained to Renee 11 years ago. That her stress about her job, her finances, her daughter, that stress was not separate from her back pain. It was feeding it.
Exactly. And the second framework I want to introduce is the fear avoidance model. When people experience chronic pain and begin to catastrophize, meaning they interpret pain as an uncontrollable disaster and believe that any movement will make it worse, and we see this a whole increase in our older adults, they develop an excessive fear of physical activity. They stop moving, a sedentary lifestyle sets in, muscles weaken, deconditioning occurs, bones get weaker, and it's easier to get short of breath when you do start moving. And paradoxically, the pain gets worse. The avoidance that was meant to protect them accelerates the very thing they were afraid of. This is why the combination of cognitive behavioral therapy and physical activity is so powerful. It does not just address the pain, it breaks the cycle of fear and avoidance that is maintaining the pain. Patients learn through guided supportive movement that they can be active without causing damage, and that learning changes the neurological experience of pain over time.
For patients and caregivers in our audience, if you have been told that your pain is in your head, that is a dismissal, not a diagnosis. But what the science is actually saying is that the pain lives in the whole nervous system, body and brain together. And that means there are entry points for treatment beyond just medication. That is not a limitation, that is an opportunity. For our nurses and nurse practitioners, you are typically the first healthcare providers a patient encounters in a pain conversation. The gate control theory and the fear avoidance model are frameworks you can use to explain to a patient why a referral to physical therapy or cognitive based therapy based pain program is not a rejection of their pain. It is a clinically grounded response to how pain actually works. For our NP entrepreneurs, understanding these frameworks positions you to build pain management protocols in your practice that are evidence based, billable, and differentiated from the default prescribe and refer model that has failed so many of our patients.
And there is one more piece of science I want to name before we get into interventions, and that is the gut brain axis in pain. We talked about this in the sleep episode in the context of the microbiome and sleep hormones. In pain, the connection works like this: emotional stress triggers the release of cortisol and other stress hormones that directly impact gastrointestinal function. This is why people in chronic pain often also experience nausea, diarrhea, constipation, and digestive disturbances. It is not a coincidence. It is the same nervous system. And the reverse is also true. Interventions that activate the parasympathetic nervous system or the rest and digest system not only reduce physiological stress, psychological stress, but physically relieve the gastrointestinal symptoms that accompany chronic pain. So, yoga, guided breathing, these are not soft interventions. These are physiological, precise ones.
And must say that they truly work. I am a sufferer of chronic pain, and a lot of times it is approached with medication. And I have found although like over the counter medication does help, I have found like incorporating yoga into like my weekly routine has helped tremendously, as well as like not focusing on like when working out is usually the cause of my pain. I think I was doing things that made my pain worse and kind of like just pivoting my workouts by doing things that were not as hard on my joints, like yoga, Pilates, and incorporating those. A lot of stretching has helped tremendously, and physical therapy. I'm a advocate for physical therapy for sure, because it works with strengthening the muscle. So pain is not just a physical event, it is a whole nervous system experience. Stress opens the gates that amplify pain. Fear of movement makes the pain worse over time. And interventions that calm the nervous system, movement, breath work, cognitive tools are not alternatives to real treatment. They are real treatment, and the evidence says so.
Thank you, Geraldine. So let's get into those interventions. The research we are drawing from today covers a range of non-pharmacologic or non-medication approaches across multiple pain populations: chronic low back pain, fibromyalgia, osteoarthritis, cancer-related pain, chemotherapy-induced peripheral neuropathy, and pain and palliative care. I want to go through each one specifically because the evidence is strong enough to name. So first, we'll talk about acupuncture and acupressure. Across 44 randomized controlled trials involving 8,338 participants with chronic lower back pain, individualized acupuncture combined with TENS or transcutaneous electrical nerve stimulation show the highest improvements in pain and disability of any intervention in the analysis, with a standardized mean difference of 3.92. So, for patients experiencing chemotherapy induced peripheral neuropathy or numbness and tingling and pain in the hands and feet, that is one of the most debilitating side effects of cancer treatment. Acupuncture significantly improved pain scores across 6 randomized controlled trials with a standardized mean difference of negative 0.62 and a p-value less than 0.0007. Those fancy numbers just means it's significant, and it means a lot. These are not pilot numbers. These are robust findings across thousands of patients. And acupuncture is something that comes up frequently in our communities as something people are curious about, but we do not know how to access or whether their insurance will cover it. For any listener who has been wanting to try it, it's worth asking your provider specifically about it as a pain management option and asking your insurance plan whether it is a covered benefit.
Thank you so much for that. And Geraldine, yeah, I forgot you do suffer with chronic pain. Thank you for sharing that with us. Let's get into some Pilates. All the girlies are doing Pilates. So, in the randomized controlled trials, you can do all kind of studies, and there's certain kind of studies depending on the way the study is set up, determine how it's graded and how much weight we give into it. Where they're the least outside factors that contribute to the answer. So when we talk about randomized, systematic meta-analysis, like we'll be doing, these are the highest level of studies. So across 6 randomized controlled trials with over 200 patients with fibromyalgia, a condition that disproportionately affects women and is frequently undertreated, and in school we're taught it was made up. We're taught that when women say they have fibromyalgia, that it's not real. Okay, now the study showed that Pilates generated significant pain reduction on what we call the visual analog scale. That's when we say, hey, can you tell us your pain on a scale from 0 to 10? And it showed that there was significant improvement in health-related quality of life. Importantly, mat Pilates, where you don't need that machine, the reformer, which you can do at home with YouTube, that mat Pilates was highly effective for pain reduction specifically. And it would work great for Geraldine because she was talking about being gentle on her joints. So while mat Pilates combined with equipment was better for quality life improvement, that distinction matters for practice owners, our entrepreneurs who are designing programs with limited equipment budgets. You're new to the field. Those reformers are not cheap, friends. This shows you it's okay. You're still going to be very valuable to your community. That distinction matters. And the research found that older adults age 50 and above with fibromyalgia experience significantly greater pain reduction from Pilates compared to younger participants, which challenges the assumption that older adults cannot or should not engage in structured exercise programs. But that's being debunked every single day, especially with social media. We see you guys lifting. Oh, then we have yoga. 2 forms. We have hatha yoga and biomechanically based yoga. They were studied in older adults with knee osteoarthritis. If back pain's number 1, knee pain has to be number 2. And now that I'm in Texas, 9 out of 10 of my patients have had knee replacements. I see incisions on everybody. Now, hatha yoga produced moderate pain reductions. Biomechanically based yoga produced large pain reductions, but also improved depression symptoms. Pain is debilitating. You're not sleeping. You can't move like you want to. You're going to be depressed, which is clinically significant because chronic pain and depression are frequently comorbid, and treating one without addressing the other is a common failure point that we're missing. Additionally, 4 sessions of laughter yoga. I tell my patients all the time about, what do you call it? Like laugh therapy. I tell them, find some comedy. Laughter is the best medicine there is. And in 4 sessions of laughter yoga in 69 cancer patients undergoing chemotherapy, the study showed it significantly reduced both their fatigue from the intervention, from the chemo, and pain, also related to the cancer and to some of the treatment compared to routine care. And a huge significance there.
So I want to pause on laughter yoga for a moment because I know some people are going to hear it and think it sounds like something you would do at a wellness retreat and not a clinical intervention, because I know that's what my thought was. 4 sessions, significant reduction in pain and fatigue. In cancer patients, specifically in cancer patients, that is in the research. The parasympathetic activation from sustained laughter is a physiological event with measurable clinical outcomes. That is what we mean when we say these tools are being underestimated.
Now, massage therapy, which we love, in veterans with advanced illness receiving palliative care. We've talked about palliative care here on the show with now Dr. Anthony Young. He talked to us about palliative and hospice. We invite you to check that episode out. So in our veterans with advanced illness receiving palliative care, a 20 to 30 minute Massage with trigger point release significantly decreased pain intensity on a 10-point scale. In women undergoing breast cancer chemo, the same technique produced over 70% a mean improvement in their nausea. That's very common. And for our nurses, there's a certain kind of massage. I'm going to mess this name up. Effleurage is a basic massage technique that falls within nursing scope of practice. You don't need a prescription. You don't have to wait for your doctor, your NP, or your PA to write this one. And it requires targeted training rather than a full massage therapy credential. This is a skill that can be integrated into clinical care with appropriate instruction. And then you can share that with their caregiver. Now let's get into Tai Chi. It's all over the internet. 21 days of Tai Chi in patients with non-Hodgkin lymphoma and colorectal cancer receiving chemo significantly reduced fatigue intensity and significantly reduced pain. It also reduced diarrhea and constipation, which brings us back to that gut-brain axis. The same intervention that reduced pain also regulated the GI symptoms driven by the stress response, one intervention and multiple benefits. Then we see our cognitive behavioral therapy in combination with physical activity. So we're not just saying you need drugs. We're not just saying you should get better sleep. We're not just saying you should do exercise. We're saying when you combine all of these, that's what we call holistic approach, you're going to get the best outcomes. Now, across 25 different studies, over 2,000 older adults living in long-term care nursing home with chronic pain, the combination of physical activity and cognitive behavioral therapy was highly effective in reducing pain, meaning how much pain disrupts their actual daily life. The combined approach addressed that fear avoidance cycle that we talked about. It helped build their self-efficacy so that they can resume activity without catastrophizing, without building up that anticipatory anxiety. This is the intervention most supported by evidence for older adults managing chronic pain, like my dad, and it is one of the least consistently offered. We love music therapy. When I'm at work and patients are blasting their music, it totally takes me to another place. And it reminds me that I don't listen to music enough. Now, a single 20 minutes, we've talked about 20 minutes, 30 minutes, 4 sessions. These are small numbers to start to see a real benefit. You have to wait 6 hours, 8 hours for another dose of your narcotic. In that time, you could try multiple of these options that we're giving you. Now, a single 20-minute session of live music therapy in palliative care patients produced over 70% improvement in agitation and significantly reduced pain levels. Virtual reality, I love this. I think this is a great opportunity for not only our nurses, we would love to hear the virtual nurse talk about this, but also our entrepreneurs. This is a wonderful opportunity. Virtual reality-based music therapy additionally improved patient usefulness and satisfaction scores by over 50%. It improved their overall quality of life. For hospice and palliative settings and for families of patients in those settings, this is clinically supported intervention that's accessible, it's low cost, and it's deeply humanizing. Now, let's go back to that virtual reality. Now, a single 30-minute session of VR travel using Google Earth in terminal cancer patients in a palliative care setting significantly improved observed pain. And in a separate study of 100 lung cancer patients using immersive VR nature environments showed no significant changes in pain or nausea. This tells us that the type and content of the VR experience actually matters. Not all VR is equivalent. The mechanism appears to be distraction-based pain modulation, engaging the brain's attention system so the pain signal competes for fewer spaces in the brain.
Thank you for sharing all of that, Kimberly. I am definitely a music girly every day. And maybe I'm not using the music for pain purposes, but it definitely is a therapy. So when I'm driving home from work after a stressful day, the music is turned up and it's cranking. Or when I'm headed into work and I need to decompress before I get my day started, music really does wonders. So I want to talk about one of our vulnerable populations, our pediatric patients. So, one pilot involving 8 children with cancer in palliative care showed that massage therapy significantly decreased both pain and worry. 8 children is a small sample, and we acknowledge that. But worry is a clinical outcome in pediatric palliative care that is rarely measured and rarely treated. The fact that a non pharmacologic intervention moved that needle matters.
Exactly. And we're talking, some of the population that we're talking about, these are some of the people who live with the most severe pain and the longest. So when we see that it's improved in them, it gives us a lot of hope if we're one of those people who are only dealing with pain for that 4 or 6 week cycle. And then I wanted to say, maybe we'll come back. So our takeaway for this section is acupuncture, Pilates, and the acupuncture, we probably should have talked about the fear of needles. It's not as bad as you think. Okay. I've had some people who were afraid of needles and they were able to get get by. The distraction. So, and I know Alicia and Geraldine can attest to this. When patients have visitors and we go check on them for their pain, they'll be like, "Oh, they were laughing with their family. They're not in pain anymore." It's the distraction. The distraction is why they are laughing, and we want them to do that. And we know that the longer someone has pain, so that chronic pain, they're not going to always have those outwardly symptoms. They're not going to have the change in the vitals that we see in someone who just fell or just had surgery. So acupuncture, Pilates, yoga, massage, Tai Chi, all of these things you can get for free on YouTube, except the acupuncture. And CBT combined with movement, the music therapy, and virtual reality all have peer-reviewed evidence supporting their use in pain management. This means thousands of people have been studied and thousands of people have benefited. And there have been people who haven't benefited. That's true too. These are not alternative therapies. We are giving you a full picture. The evidence-based clinical tools that have been tested in those randomized controlled trials across thousands of patients across the globe. If your care team has not offered them to you, you're allowed to ask for them. Now, we established in the clinical briefing that the research we reviewed did not contain specific disparity data for Black and Brown communities, and we named that as a gap. What it did contain was detailed data on two populations that our communities overlap with significantly: veterans and older adults. So let's go a little bit in more detail with that, because the time that you're watching this is May, and we're celebrating Older Adult Awareness Month. Now, our veterans experience severe pain at a rate of 50% more than those of us who did not serve. Among younger veterans, age 18 to 39, the disparity is even higher. You wouldn't even think that, right? Now, returning deployed veterans show 40% prevalence of chronic pain, heavily comorbid with PTSD at around 30%, and traumatic brain injury. And opioid use, that's your narcotics, for chronic pain is nearly 4 times higher in the military compared to civilians.
Wow. That last number needs to sit for a moment. 4 times higher. Veterans who were sent into environments that cause physical and psychological trauma are 4 times more likely to be managing that pain with opioids. And the research is telling us there are evidence-based non-pharmacologic alternatives that have been tested and shown to work. The gap between what veterans are receiving and what the evidence supports is not a clinical gap. It is a systems gap.
Yeah, and that means the whole system, right? You need a whole restructure. It's not just that one person that's helping you at that time, right? They're part of a bigger system as to why that's happening to you as the patient. Now, veterans face a unique risk profile that includes exposure to hazardous chemicals, radiation, and combat trauma, all of which contribute to a pain experience that's physiologically and psychologically distinct from civilian chronic pain. The comorbidity of chronic pain with PTSD is particularly significant because PTSD activates the same stress response pathways that open the pain gates we discussed earlier. You can't effectively treat chronic pain in a veteran without addressing their PTSD. That is physiologically amplifying it. This is the whole person clinical conversation. And non-pharmacological interventions like CBT, yoga, and mindfulness are directly relevant to both conditions simultaneously. I always said, especially when I was at the bedside, and even now, because I work with a lot of specialty teams, so I don't actually prescribe pain medicine myself that goes, that's oral. I do make recommendations all the time though. Is that I strongly believe if we actually address people's mental health, they wouldn't even need the pain medicine that much, because a lot of times they're using that pain medicine to address their anxiety, depression, or insomnia. And if we actually address those issues, the patient who said they don't really want to take them, and the nurse who doesn't really want to give it or can't give it, right? It's not time, or the doctor won't order it, can still help them. Now, for veterans in our audience, if you're managing, like my dad, thank you for your service, or my uncle, or my love bug, if you're managing chronic pain and have not been offered a non-pharmacological option, you can request a referral to a VA whole health program. The VA has been expanding its integrative health offerings, including acupuncture, yoga, and CBT-based pain programs. These are covered benefits. And I can vouch, because my love bug just came back from a bunch of training. He said they were doing yoga, and he just re-enlisted in the reserves. So it's been, I guess, 20 years. So he's been able to see the change in the military in that time span. And these are covered benefits, and you're entitled to ask for them.
If you smoke and you want to quit, first we want you to know that quitting nicotine is one of the hardest things a person can do. Not because you lack willpower, because nicotine physically rewires the brain. This is not a character issue, this is a chemistry issue, and you do not have to do it alone. Here are your options. Nicotine replacement therapy, patches, gum, lozenges, and inhalers reduces withdrawal symptoms by giving your body a lower, controlled dose of nicotine while you break the habit. They are available over the counter. Chantix is a prescription medication that reduces cravings and makes smoking less satisfying. It is one of the most effective cessation medications available. Bupropion is another prescription option that reduces cravings and is especially helpful for people who also experience depression. Counseling and behavioral support, whether in person, by phone, or through an app, significantly improve quit success rates when combined with medication. Call 1-800-QUIT-NOW for free telephone counseling. Visit smokefree.gov for free apps and text support. And talk to your care team about which option is right for you. Quitting is possible, support is available, and you deserve both. This message is brought to you by the Melanin Initiative Podcast, where we simplify health information so you can advocate for yourself and for the people you love. Find us on Apple and Spotify. Right. And for the family members and caregivers of veterans, you are often the person who accompanies them to these appointments, who helps them navigate the system, who notices when the current approach is not working. You are also allowed to ask questions that your loved ones may not ask themselves. Bring the episode to that conversation. Older adults. The management of chronic pain in older adults is especially challenging due to the complex relationship between age-related physiological changes and comorbid conditions. Older adults they're typically hesitant to discuss their health concerns and the adverse effects of pharmacological treatments. That is a direct quote from the research. The hesitation to discuss health concerns is a clinical barrier that providers must actively address, not by waiting for older adult patients to bring it up, but by asking directly and creating the space for the conversation for the older adult patient. What the research also found is that older adults respond better to interventions framed around living well with pain rather than eliminating pain entirely, particularly in populations who have already experienced numerous failed pharmacological attempts. This is reframing that matters clinically. If a patient has been chasing a pain score of 0 for 11 years and never gotten there, the goal of living well with pain is not a lesser goal. It is a more honest and more achievable one. And this is not just for older adults. This is for myself as well. Like I mentioned earlier, I suffer from chronic pain, and honestly, I'm like always in pain. But there are days where my pain is like at a level of a 2, which I'm okay with living with. So my goal is never to be at 0. So it's great that we need to like kind of reframe our thought process of that pain score. And then for our nurses and nurse practitioners, when you are having a pain management conversation with an older adult, or with anyone for that matter, ask how the pain is affecting their daily life, not just how bad it is on a scale from 0 to 10. The Brief Pain Inventory and the Roland Morris Disability Questionnaire assesses pain interference and functional impact, dimensions that tell you far more about a patient's lived experience than a single number.
Thank you, Geraldine. And for older adults in our audience, pain is not a normal part of aging, which sometimes is a stigma that is out there in the world and that you're supposed to endure. It is a clinical symptom that deserves a clinical response. You are not being dramatic. You are not overreacting. And you are allowed to tell your care team that what you've been offered is not working, and ask what else is available. I want to circle back to the pain score. It's okay to say, no, I'm not going to be a 0, but I'd like to be at a 2. So let's talk about how to get you to a 2 if a 0 is not realistic, but you don't have to be comfortable living at a 5. So let's talk about what is going to be comfortable for you so that you can continue to live your life to the fullest potential. And for our LGBTQIA plus community, older adults, or LGBTQIA plus older adults, chronic pain management is a space where discrimination and dismissal have been documented. If you have experienced your pain being minimized or your identity being a barrier to receiving the same quality of care, That is not acceptable and is not something you have to accept. Patient advocates and patient rights organizations can support you in navigating those situations. I would even say bring someone with you and have that person be your advocate as well. It's harder to tell two people no than one. For pediatric patients and their caregivers, pain in children is frequently undertreated because providers underestimate it or because children lack the language to describe it precisely. If your child is in pain, you are the most important advocate in the room. Bring the observations, bring the patterns, and specifically what non pharmacologic options are appropriate for their age and condition. Parents, you know your children best. So, our takeaways from this section are veterans are carrying pain at rates 4 times higher than civilians and being managed primarily with opioids when evidence based alternatives exist and are available as VA covered benefits. Older adults are being undertreated for pain and under asked about it. And you are allowed to ask for more than what you have been offered. The evidence supports it.
So before we bring Renee back, Renee is we introduced Renee at the beginning of this episode. Here, before we bring her back, here are your action items. If you are a patient or caregiver, at your next appointment, ask your provider specifically what non-pharmacological options are available for my pain. Name the ones from today if you need to, such as acupuncture, Pilates, yoga, massage, Tai Chi, CBT combined with physical activity, music therapy. Ask for a referral. And I know we mentioned earlier about like insurance. You always have to, always ask because you never know what your insurance will cover. And also, I know that some like yoga studios even take like FSA and HSA cards. So like even if your insurance doesn't cover it, and if you have like an FSA or HSA, that is something that you can use to pay for it. You just have to make sure you get like certain documentation from your healthcare provider. So just throwing that out there. But yeah, if your pain has not been assessed with a validated tool, ask your provider to use one. The brief pain inventory is a starting point. And if you are a veteran, ask specifically about the VA Whole Health Program and what integrative health services are covered. If you are a nurse or nurse practitioner, add a pain interference question to your intake. Not just a numeric scale, but how is the pain affecting your daily life, your sleep, your ability to work, your relationships? If your patient screens positive for chronic pain, explore non-pharmacological referral options. Understand which interventions fall within your scope of practice and which require a referral. Effleurage massage, guided breathing, and VR deployment are within nursing scope with appropriate training. If you are a healthcare entrepreneur and cosmetic NP, chronic pain is one of the most common reasons people delay cosmetic procedures, avoid follow-up care, and disengage from your practice entirely. Building non-pharmacological pain management resources into your patient education and knowing your referral network for pain differentiates a comprehensive practice. Standardizing pain assessment at intake is also a documentation and billing opportunity that most cosmetic practices are not utilizing.
Okay, let's go back to Renee. After her last flare, her daughter found this episode and shared it with her. Renee went back to her provider, a different one this time, and brought 2 things with her: a completed brief pain inventory she filled out at home, and a list of questions. What non-pharmacological, that means not drugs particularly, options that are available. Has my pain ever been assessed with a validated tool? And can I get a referral to a pain program that includes movement and behavioral support? Her new provider referred her to a physical therapist who used CBT-informed approach alongside targeted movement. She started a community Tai Chi class at the recreation center 2 blocks from her house. I hope she walked there. It was free, and they did it twice a week for adults over 40. And she downloaded a guided breathing app and uses it for 10 minutes before her shift starts. Or you can go on YouTube and find a free one too. And her pain has not disappeared. She's not chasing zero anymore. That's managing expectations. She's chasing function, and she's getting it back. She has not missed a day of work in 4 months.
Yay, Renee. Awesome. So nobody gave Renee anything new. They gave her information she had always been entitled to and was never offered. That is what health literacy does. That's what we do for you guys. It changes what you know to ask for.
11 years. She managed 11 years of pain without anyone offering her the tools that were available the entire time. That is the gap that this podcast exists to close.
Today's episode drew from peer-reviewed research on acupuncture, Pilates, yoga, massage therapy, Tai Chi, cognitive behavioral therapy combined with physical activity, music therapy, virtual reality, and aromatherapy across populations including older adults, veterans, cancer patients, fibromyalgia patients, and pediatric palliative care patients. And when we talk about aromatherapy, I know when we worked together, we used to use lavender.
We did.
And I tell my patients that all the time. Yeah, you didn't need you didn't need an order from the doctor. The nurse could pull it from the supply room, give it to our patients, and they used it both for their pain and their anxiety. Oh, I love that. And we'll be learning more. And another thing that I wanted to add, the reason we do that we're doing this episode in particular, and kind of the lens that we come to you by, is because we're not taught this either. So when you go to your appointments, you can't depend on the person standing in front of you to be equipped with this information. Then you have to ask yourself, well, why not if it works? Well, that comes down to the business side of healthcare. It's a business. And the things that make the most money, that's what we're taught. That's what we're mandated to continue to reinforce. That's what we get paid for. So that's your medications, that's your surgeries. Those are the things that cost the most money. So we're equipping you with this information, and hopefully you feel empowered that no matter how long your appointment, no matter what you're there for, that you can ask these questions. You have to ask for the care that you want. That's what I've learned in the length of time that I've been doing this, that the patients who get the best care have that advocate Alicia talked about, and they're empowered with information. And then they stop and they ask me. And guess what I do? I stop and I listen. And then if I don't know anymore, if I don't know what they're talking about, I go look it up. And together we help the patient, because it's only about you, reach the goal that they want to get to. Okay. All the sources that we talked about today will be linked in the show notes. And we should have Angie's going to put up a graphic that you can screenshot so you can take this with you and share it with your friends and your family so everyone can get better care. And the person who's helping you, whether that's your doctor, your nurse, your NP, your PA, your social worker, whoever it is, can also feel like they actually helped you too. Because sometimes even we feel a little bit helpless and limited based on our scope and where we're practicing. And together we can feel like we actually achieved something.
Love it. So I'm going to piggyback off of Kimberly and say, if this episode gave you something, share it. Someone in your circle is Renee. You might be Renee. They have been managing pain alone with tools that are not working because nobody told them what else was available. Send them this episode. Find us on Apple Podcasts and Spotify. Leave us a review and tell us what topics you want us to cover next. This podcast exists because of this community. And if you are a nurse practitioner who wants to go deeper on the business and clinical side of healthcare entrepreneurship, visit Mahogany Dermatology Nursing and the Alliance of Cosmetic Nurse Practitioners. Links are in the show notes. If you found this information helpful, check out our episodes on medical billing and insurance. We are the Melanin Initiative. Until next time, take care of yourselves and take care of each other.